Afternoon, friends, and today we'll be speaking on very important topic, tetralogy of Fallot. And as a pediatric cardiologist, it is our responsibility to, take care of them pre-operatively and assess them properly. So, surgeon won't have difficult time in operation theater and post-operatively as well. So I can, make it very interactive. Just give me a moment. Kavita, how many of them are getting couple of questions in between? And please answer those questions without any hesitation. So in tetralogy of Fallot, there is very important thing, that is a variety of anatomical and clinical presentations. You all must have seen a cyanotic newborn with tetralogy of Fallot pulmonary atresia saturating 40, and you all might have seen 10-year-old boy with tetralogy of Fallot saturating 85 to 90%. So this is very interesting subset, and we should be aware about variety of presentations. Mm, uh, as we all know that various kind of patients can have various type of anatomy, so that treatment options also are tailor-made, and they are institution specific also. Let us say when we talk about complete repair in tetralogy of Fallot, some of the centers are doing complete repair at the age of even 3 to 4 months. And some of the centers are still doing complete repair at the age of 10 to 12 months, and they are comfortable at that age. So decisions have definite influence from surgeon's perspective, intensivist perspective, and we all should respect those concerns as well. So when a patient with tetralogy of Fallot comes to your unit, the decision is collective based on local protocols. Now here, as name suggests, that there are two important topics: one assessment and another medical management, and we'll touch upon both of them one by one. Now history, in clinical assessment always begins with history. So we will deal assessment in different topics like clinical assessment, echocardiographic assessment, CT scan assessment, and case assessment. So let us begin with clinical assessment, and history is very important. We all should inquire about cyanotic spell related histories, history regarding tetralogy of Fallot complications like any past history suggestive of brain abscess or stroke, or other symptoms, depends on any non-cardiac issues. So everything should be documented in a great detail. And clinical examination, as we all know, it is characterized by ejection systolic murmur and single second heart sound. Can anyone tell what is the relationship of this murmur with the clinical presentation or the degree of stenosis? Can anyone type in the chat box? Anybody? Murmur less, okay. Severe cough, less murmur. More severe RTO, shorter, softer murmur. Okay, so very nice, Dr. Singh and Dr. Rajesh Kumar. Thank you so much. So, severity of stenosis, more severe is the murmur, shorter and softer murmur, and less severe is the stenosis, longer murmur, louder murmur. So all of you, three of you have typed it appropriately. Blood pressure. Can Shilpa Patil or Rajesh Kumar tell me about blood pressure? What can happen in long-standing untreated tetralogies? Shilpa, Rajesh, anybody? Adults can have hypertension. Why? Very good. Why? Hypertension. Why? AR leading to white blood pulse pressure. It's okay in presence of aortic regurgitation, but suppose, let us say, patient doesn't have aortic regurgitation. What is the cause of high blood pressure? Somebody has written it right. Probably Shilpa, who wrote it right. Shilpa Patil has written it correctly. It is hypertension. What is the cause of hypertension, I am asking? C, aortopathy is not the right answer. C, in patients with tetralogy of Fallot, there is natural tendency to increase SVR, and by increasing SVR, nature is trying to increase left to right shunt across the ventricular septal defect. So, chronically elevated systemic vascular resistance in cases of tetralogy can cause, this hypertension. So, we should look for it, and it is not that uncommon in grown-up talk. Now, clinical assessment also includes chest X-ray and ECG. Now, how do you suspect unilateral branch pulmonary artery stenosis or hypoplasia or atresia by just looking at chest X-ray? Can anybody type in the chat box? Dr. Shilpa, Dr. Rajesh Kumar, Dr. Singh, anybody? My question is differential vascularity, right? Excellent. So, in order to determine pulmonary blood flow, we should be careful while looking at the chest X-ray. And clinical examination itself can make us suspect that this patient might have, unilateral branch PH stenosis or hyperplasia or atresia. What is the chest X-ray evidence of aortopulmonary collaterals? Can anybody tell? Dr. Odil Lankar, reticular pattern, that is the right answer. Lacy reticular pattern, rightly described by three of you. Thank you so much. So, and in cases of aortopulmonary collateral, there is a particular honeycomb type of appearance and classically known as Lacy pattern. In ECG, what is the early transition from V2? Can anybody tell me? Dr. Shilpa, Rajesh, Odil, Dr. Singh, Dr. Mahendra Singh Parihar is joining the meeting. What is the early transition from V2? Okay, fine. So almost all of you have answered it right. Sudden transition of R wave from V1 to V2, where we can see equiphasic R and S from V2, and it's known as sudden transition. Rhythm. What kind of arrhythmias are seen in patients with tetralogy of Fallot? Dr. Odil, Dr. Singh, Dr. Shilpa, please type it fast. What kind of arrhythmias are seen in patients with tetralogy of Fallot? Nobody? Okay, right. Dr. Shilpa has written ventricular premature beats, atrial tachyarrhythmias, right? Jet, it is commonly seen in post-op patients. Fine. So good. So basically ventricular premature beats, and sometimes even VTech is seen in patients with ventricular dysfunction, especially patients with RV or LV or biventricular dysfunction can have ventricular arrhythmias, and obviously atrial arrhythmias are also known. Okay, now very important topic, echocardiography. So we should look at the size of the VSD, location of the VSD. Now we all know that location of the VSD is perimembranous, malaligned type of VSD. People also call it as a subaortic VSD. Everything is the same. We can have additional VSDs, and how like additional muscular VSDs, and how you guys identify additional muscular VSD in echo. Any particular technique you are using, or anybody would like to answer? What should we do? Decreasing Nyquist limit is the right answer. Right. So reduce color scales, decreasing Nyquist limit, everything is same. So because it is a low flow situation, and sometimes we can miss, and plus these VSDs are something bidirectionally, low velocity jets, so we may miss them. What is so peculiar about outlet VSD is that this classical VSD can have outlet extension, or sometimes VSD itself is purely outlet VSD. So what is so peculiar surgical thing about outlet VSD, and why surgeon want to specifically know whether there is outlet extension or outlet VSD? Dr. Amol Gupta, Dr. Singh, Dr. No, AR, there is no relationship with AR. AR is common, that is okay, but as a cardiologist, we would definitely report about aortic regurgitation during our echo report. But why? Okay, outlet VSD, approach to pulmonary valve, approach to main pulmonary artery is the right answer. But still, one more important thing which nobody is writing is that in patients with outlet VSDs in tetralogy, incidence of transannular patch is high, and invariably surgeon would like to put a patch there to enlarge that area. So patients with outlet VSD have higher incidence of transannular patch. And we have spoken about the size of the VSD and restriction. Okay, what can restrict the VSD in TOS? Be quick, please. Dr. Odil, Dr. Patil. Septal tricuspid leaflet, that is the right answer. And how is it important? What changes can happen in hemodynamics of tetralogy when there is RV dysfunction? Is the right answer. Suprasystemic RV pressure, because we have two outlets of right ventricle in patients with tetralogy. One is across the VSD and one is across the pulmonary valve. So when both outlets are restricted, one is pulmonary stenosis, which is already restricted, and your VSD is also restricted, RV becomes suprasystemic, and there is invariable incidence of RV dysfunction. Aortic override varies from 10 to 100%, and you all might be aware that different people speak about different definition of double outlet RV. A more common definition is that if there is aortomitral discontinuity, people call it as a double outlet right ventricle. But friends, for surgeon, even if aortic override is more than 50%, like let us say 70 or 80%, which is quite common, for them it becomes long patch and long tunnel, and they call it as DORV even if there is aortomitral continuity present. So it is very good idea to inform surgeon that what is the degree of aortic override, and arch-sidedness is important, especially for planning a BT shunt. However, irrespective of side of the arch, nowadays surgeons perform BT shunt nicely, but still it is good idea to inform about the arch-sidedness. Right ventricular outflow tract is a very unique structure, and we have to pay attention when we look at the RVOT of normal individual. It is a wide, roomy RVOT with proper length to it. But in various type of tetralogy of Fallot, RVOT can vary in size, shape, length considerably, and we have seen patients with we all have seen patients with tetralogy of Fallot with very nice RVOT, isolated infundibular stenosis or isolated valvus stenosis, versus we also have seen patients with TOF with shorter RVOT, narrower RVOT. So, it's not just pulmonary valve, it's not just degree of stenosis, whether it's infundibular valvar or supravalvar. We have to document it, but we also have to inform surgeon that how is the right ventricular outflow tract, because many times there is the requirement of RVOT patch with or without transcatheter patch. And pulmonary valve Z-score are important nowadays. It's in parameters.com. It's quite easily available. You have to just fill in the age of the patient, weight, length of the patient, and you just add value and you will have Z-score. And what level of Z-score you feel that transannular patch can be avoided. For -2 people are fast. So my question was vice versa. Anyway, so if it's less than -2, then there is chance that, very high chance that it will be, a surgery with transannular patch. And if it is more than +2, then it's very high chance that, it will be annular sparing surgery. And very simple question, why are we so worried about whether it is annular sparing patch, annular sparing surgery or transannular patch? Why? What is the reason? Pulmonary regurgitation, free PR, right? So it completely changes the outcome. Children with annular sparing ICR are the ones probably, it's the children with excellent prognosis, and it is first and probably last surgery of his lifetime and completely normal life, versus those with free pulmonary regurgitation can have progressive dilatation of right ventricular outflow tract, and need of pulmonary valve replacement and so many other things. It's beyond today's topic, but it's very important, and it is a very good idea to inform surgeon that this particular anatomy, I feel that probably annular sparing surgery should suffice, or I feel that there may be requirement of patch on MPA, because MPA is smaller. There is a narrow RVOT. I feel that RVOT may need a patch or something like that. So it's not just of diagnosis, and you have to discuss in a great length with your surgeon in order to achieve the better outcome and to prevent second bypass run, because we have seen in OR that sometimes because of lack of information repair is suboptimal, and sometimes they may have to go on pump again. So it's all add to the patient's survival, and we have to be very, very careful about any diagnosis in pediatric cardiology before they going into OR. And let me just add to this point that whenever we have seen echo, it's fine. But a patient who is undergoing open heart surgery, we must be doing echo just a day prior, just to make sure that everything is okay. If surgeon wants to see the images, show him or her the images and discuss it out. It is all helpful, believe me. Pulmonary arteries, again main pulmonary artery, right and left. We have to have Z-scores. There can be hypoplasia, atresia or absence of unilateral pulmonary artery. There can be just a short segment stenosis or there can be long segment stenosis. So we have to really verbalize what exactly anatomy of pulmonary artery. Aortopulmonary collaterals. Now, if patients with tetralogy of Fallot with significant overflowing aortopulmonary collaterals, what will be the indirect signs in echo? Please type in the chat box. Dr. Singh, Dr. Rajesh Kumar, Dr. Shilpa. Flow reversal in aorta, that is 1. Okay, good size LA and LV. Very nice point from Dr. Shilpa. Fine. So basically, increased pulmonary venous return flows. So these are the signs which will tell us that probably, this aortopulmonary collaterals are significant. We should look for them, especially in arch area if there are collaterals, or from neck vessels we can see during echo, but mid-thoracic aorta or descending aorta, direct visualization of collateral is really difficult, but we should make a habit to look for, at least to look for if there are any collaterals seen during echo. PDA we should look at, and what is the commonest site of LPS stenosis in patients with tetralogy? Dr. Rajesh? Okay, so PDA insertion site is the right answer. And if patient has undergone BT shunt, we should look for, BT shunt. And we should look at the patency of the BT shunt and, things like that. Coronary artery, very important with the coronary is crossing right ventricular outflow tract or not. We should look at the right coronary artery and importantly left coronary artery. We all are aware about the various types of abnormal coronary anatomy in tetralogy. But let me ask, what is the commonest coronary abnormality in TOF? Dr. Odil, Dr. Shilpa? Only one person has answered. Okay. So basically, LAD from RCA or conal branch of RCA, these are two common type of abnormal coronary anatomy. Indirectly, if we properly see and if we can see coronary artery right and left properly without any problem, means there are very high chance that nothing is crossing RVOT, but we have to carefully look for it. What are the views in which we should look for coronary anatomy abnormalities? Subposterior short axis. What is another important view apart from, it's not apical four-chamber, it's something else. Short axis is right answer, but another additional view is peripheral long axis, RV outflow view, or apical four-chamber RV outflow view will also show you nicely if there is any coronary crossing RVOT. And we also must mention that what is the distance of this coronary artery from pulmonary annulus. Likewise, we can say that we are seeing one important and prominent conal branch of RCA crossing RVOT, which is approximately 6 mm distal, 6 mm distal to the pulmonary valve. Distal, I mean that towards RVOT. We can also say proximal. So the distance from coronary artery to pulmonary valve annulus is very important, and surgeon will be prepared accordingly. Additional points: ventricular function. What is the commonest ventricular function abnormality in untreated tetralogy? Rajesh, Shilpa. Dr. Singh, what is the commonest ventricular function abnormality? Nobody? Okay, right ventricular diastolic dysfunction is the commonest abnormality, and we should look at it carefully. We should also look for LV dysfunction, which is sometimes associated. And patients with long-standing cyanotic heart disease can have ventricular dysfunction, which is popularly known as cyanotic cardiomyopathy. We should look at bilateral superior vena cava, ASD, pulmonary veins. Again, we should reduce the color flows to appreciate pulmonary vein abnormality, aortic wall incompetence, ascending aorta dilatation. Sometimes old healed vegetations are present in such patients, and we should document them. Nowadays, availability of good CT scans, we can refer patients for further evaluation. Pulmonary artery, epicollateral, coronary artery abnormality. If we have any doubt in these 3 points, we should subject them for CT scan. Nowadays, CATH is rarely used for assessment of tetralogy. However, there are still few indications where CATH is very important, like TOF, pulmonary atresia subset, especially for epicollateral and PA anatomy, so that surgeon can plan surgery like unifocalization appropriately. And by and large, such patients undergo both CT and CATH. We should also look at, when we are having doubt about additional VSD, in spite of transthoracic and transesophageal echo, we can do LV angiogram and make sure that whether there are additional VSDs or not. Distal pulmonary artery arborization is better delineated by CATH. And as we all know, if patient with tetralogy is not behaving well after surgery, and if we want to study patient's hemodynamics, residual VSD, RVOT, additional VSD, things like that, CATH is very, very helpful. So, any doubt so far in patients with tetralogy of Fallot? Assessment point, clinical, echo, CATH, CT, any doubt, any questions so far? So we can, okay. So thank you so much. Now, medical management, and most important point is education of parents. We have to educate them that this is a treatable problem, they can live a good life after surgery. Additionally, patients with newborn with tetralogy of Fallot, they are stable newborns. We follow them periodically, and we have to ensure certain points. First and foremost is plenty of fluids. We have to tell them that your baby should never get dehydration. If you have episodes of vomiting or diarrhea, the threshold of hospitalization and IV fluid should be very, very low, so that we can avoid cyanotic spells. Dehydration is commonest cause in India for cyanotic spell. Parental education, as we have discussed, and we also should educate them about the signs of cyanotic spells and Nietzsche's position whenever they feel baby is going into spell. And my own experience, if I share, whenever I see newborn with heterologous fellow, asymptomatic newborn, and if patient comes for follow-up very, very regularly, if they follow our medicines, like traditionally people typically start iron from newborn period itself as soon as diagnosis is made, and propranolol from the age of 1 month. If they take it regularly and if they follow with us regularly, when we increase the dose of propranolol and iron as and when they are gaining weight, if everything is fantastic, then I have seen them behaving quite well without any symptoms, and majority of them remain pink tetralogy till correction. So it is very important duty of pediatric cardiologist, and in collaboration with pediatrician, ensure regular follow-ups. Iron is very important, and to optimize hemoglobin. Iron deficiency anemia can cause sometimes we may have to give packed RBCs to optimize hemoglobin, and hematocrit peripheral smear is very helpful. Propranolol, typically we start 1 mg per kg per day, and if they become cyanotic, if their saturation start falling below 80, we go up to even 3 to 4 mg per kg per day. And we all have to monitor heart rate appropriately. One question, why generally we start propranolol at the age of 1 month and not before that? Any particular reason? We can start, there is no harm in it, but typically we start it at the age of 1 month. Anybody? Dr. Rajesh? Correct. So beta receptor activity is not mature, so basically autonomic nervous system is not very much mature. So probably last 2 slides, management of cyanotic spells. I am not going into great detail because all of you are aware, but let me just touch upon important topic. Important part of this management is oxygen first and foremost, then knee chest position, then sedation. Morphine is drug of choice, but sometimes if it is not available, we can use midazolam or fentanyl. Beta blocker, IV propranolol and metoprolol both are available, but IV metoprolol is easily available. So give IV metoprolol 1 dose, ketamine, phenylephrine as and when required, depends on response to previous agents. And then last but not least, if patient is having refractory spell, we can ventilate the patient and can send patient for even surgery if patient is not recovering. So carry home messages are the meticulous assessment of patient with tetralogy preoperatively is very important, and there is a variety of presentations, anatomical as well as clinical, and we have to pay attention to minute details. Medical management is very important because we have to make sure that baby grows appropriately till baby is on the surgeon's knife. So good weight, better saturation, slightly higher age, more than 6 months. If we can pull on, then surgical results are much better. So these are the points for medical management, and probably thank you so much. Any other question if you guys have regarding this, please feel free to ask, and then probably we can wind up in a couple of minutes. Any question from all these people have nicely participated. Dr. Shilpa, Dr. Rajesh Kumar, Dr. Mahendra Singh, Dr. Amito Singh, all of you have nicely answered all of majority of the questions, I must say, and few other people remain silent, but this question I expected, cause of sudden transition in ECD patients with TOF. There are various explanations given, and I'm sure you must be aware about various explanations, but one of the important explanation which is commonly talked about is the peculiar nature of the VSD. The lead V2 is directly on the area where there is a VSD, and it is acting like a electrical window to to transmit these waves to earlier leads. So VSD is acting as a window to have this electrical abnormality. It is commonly discussed. However, there are other other points, other kind of explanation also given. So this widely accepted explanation is this, that VSD is acting as a window, and thereby we can see peculiar R wave transition from V2. Any other question apart from this? Dr. Rajesh Mahendra, indication of transpulmonary valve. This is beyond the purview of our discussion, and maybe there are many hemodynamical aspects into it. So probably a person who will be dealing with TOF surgical management can ask to that particular person, because this will be out of the topic question, so I am not answering it. Any other question regarding clinical assessment and pre-operative management? Okay, so thank you so much all of you.